Welcome, curious minds, to the deep dive. Today, we're plunging into a world that's often unseen but profoundly impacts global health. Did you know that parasitic infections, even though they might seem rare where you are, they actually affect an astounding number of people globally?
Oh, absolutely. It's quite staggering.
Take Schistosomiasis, for example, just one disease impacting hundreds of millions. It's a huge number.
It really puts into perspective how vast this challenge is, doesn't it?
Yeah.
Truly highlights the global burden of these often, well, neglected tropical diseases.
It absolutely does. So our mission today really is to cut through the complex layers of these dense medical texts. We want to bring you the most crucial and honestly the most fascinating aspects of helminthic infections. We're specifically zeroing in on flatworms today. That's trematodes, which you probably know as flukes, and cestodes, the tapeworms.
Right, flukes and tapeworms.
By the end of this exploration, our goal is for you to gain what we call an elite level understanding. We're talking chapter 234 and related topics from our source material.
Getting really deep into the details.
Exactly. We want you feeling incredibly well-informed on these major global health challenges, really mastering this information, almost like a professional in the field.
In our deep dive today, it pulls directly from detailed excerpts of a proper medical text.
Yeah.
It offers a really precise look at these organisms, their incredibly intricate life cycles, their profound impacts on human health,
Yeah.
and the surprising, sometimes quite ingenious ways they interact with the human body just to survive.
And what I find genuinely mind-bending as we get into this are the sheer lengths these tiny creatures go to simply survive and reproduce within a host. Within us.
It's an evolutionary arms race, really.
We're about to unpack some truly incredible strategies. Okay, so before we dive headfirst into the flatworms, let's maybe take a quick panoramic view. Just look at the broader landscape of helminthic infections to set the context.
Good idea. Helps frame it.
Our source briefly spotlights another significant parasitic infection, dracunculiasis, guinea worm disease. It's a really striking example when you look at disease eradication efforts.
Dracunculiasis is, but particularly stark and fascinating case study. Its diagnosis is remarkably straightforward, almost brutally so.
How so?
Well, it's based on the direct visual finding of the adult worm, slowly emerging from the skin.
Wow.
There's no sophisticated lab tests needed when you can actually see the culprit right there.
Right, it's not something requiring high-tech diagnostics. You literally witness the worm, sometimes a meter long, making its slow, painful exit.
Painful is the word.
And the treatment, or maybe the process of extraction, is equally, primitive. It hasn't changed much for centuries, has it?
Not really. It involves slowly winding just a few centimeters of the worm onto a stick each day.
Every day.
Every day. It's a painstaking process that can take weeks, sometimes even months.
Weeks.
Oh.
And what's truly striking is that there are no effective drugs, right? Nothing to kill the worm once it's inside you.
That's correct. No effective drugs. Surgical excision is possible sometimes, but that traditional winding method, it persists as a common, though incredibly arduous approach.
This complete lack of a pharmacological cure, it means prevention becomes, everything. It's the undeniable cornerstone of control.
Absolutely. As our source emphasizes, prevention, primarily through providing safe drinking water, is the only real control measure, period.
That just highlights its profound public health relevance, doesn't it? And why global eradication efforts, which are hinted at in further readings, have been such a long, challenging journey.
It truly illustrates the sheer complexities of disease control on a global scale, where something as basic as infrastructure, like clean water, plays such a pivotal role.
It's fascinating how a single visible worm like dracunculiasis can hold such a grip, demanding that kind of focused prevention. But now let's pull back and truly plunge into that unseen world, the one impacting millions globally. Our main focus today is the vast phylum of flatworms, Platyhelminthes. This group is home to both the tricky trematodes, the flukes, and the segmented cestodes, which most of us know as tapeworms.
Yes, trematodes or flukes. They're characterized by their macroscopic size. You can actually see them, typically ranging from just 1 millimeter up to several centimeters.
So not microscopic then?
Generally not the adults, no. Morphologically, they're dorsoventrally flattened. Think flat like a leaf or maybe a coin, rather than round like a nematode.
Okay.
They also exhibit bilateral symmetry. You can divide them into two mirror image halves, much like us.
As a key feature.
A crucial identifying feature is the presence of two suckers, an oral sucker near their mouth and a ventral sucker on their underside. They use these to really anchor themselves firmly to the host's tissues.
Got it. Suckers for staying put. And then we have the cestodes, the tapeworms.
Distinctly different in structure, yes. They're segmented flatworms. That gives them that characteristic ribbon-like appearance. And that segmentation allows them to grow to, frankly, incredible lengths inside the host's intestines.
Okay, so what becomes immediately clear is that even though both groups are flatworms, their specific structures, their life cycles, and critically, the diseases they cause, they're quite distinct.
Very distinct. And that distinction really sets the stage for our detailed exploration today, especially as we dive into Chapter 234, which focuses primarily on trematodes, the flukes.
Okay, let's unpack this in granular detail. Let's start our deep dive into Chapter 234, Schistosomiasis and other trematode infections. This is where we really start building that elite-level understanding of these fascinating and, well, somewhat alarming creatures.
All right, starting with the general characteristics of trematodes. Their morphology and basic biology are quite specific, as we touched upon. They are macroscopic, visible, ranging from millimeters to centimeters.
Right.
Their body plan, dorsoventrally flattened, bilaterally symmetric. That shape helps them move through tissues efficiently. And those two suckers, oral and ventral, absolutely crucial for attachment inside the host. Helps them resist being washed away by bodily fluids.
Now, here's where it gets really interesting, particularly with reproduction. Almost all human parasitic trematodes are hermaphroditic, right?
That's correct. They possess both male and female reproductive organs in the same individual. So they can potentially self-fertilize or cross-fertilize with another fluke if one's nearby.
There's a huge exception, a defining one.
Yes, the schistosomes. They are unique among human parasitic trematodes. They have separate sexes, distinct male and female worms.
That's a really key distinguishing feature for them, isn't it? And it must influence their whole life cycle and how they behave in the host.
Absolutely, it shapes everything.
Yeah.
And their life cycles are remarkably complex, a real testament to their evolutionary adaptability. They always involve a mammalian, usually human, definitive host. That's where the adult worms reach sexual maturity and reproduce.
Okay.
But then they require an intermediate host, typically snails. And inside the snail, the parasite undergoes a phase of asexual multiplication, basically cloning itself many times over.
Wow, asexual multiplication in the snail.
Exactly. And what's even more intricate is that some trematode species actually utilize more than one intermediate host in their journey. Adds another layer of complexity to how they're transmitted.
Okay, so how do humans actually get infected by these flukes? You mentioned two main routes.
Two primary well-defined routes, yes. For schistosomiasis, it's direct penetration of intact skin. The infective larval stage, called cercaria, released from freshwater snails, just drills right through your skin.
Straight through the skin?
For many other trematodes, infection happens through ingestion. So you eat something contaminated.
Like what?
Raw or poorly cooked freshwater fish, maybe crustaceans, or even aquatic plants that contain the metacercaria. That's their specific infective larval stage, usually encased in a little protective cyst.
Got it. Skin penetration for schistosomes, ingestion for many others. Now, what about their behavior inside us?
A critical point here about their in-host behavior. Adult worms do not multiply within the mammalian host.
That's a really important distinction, unlike bacteria or viruses.
Exactly. It's a common misconception. Once that larval stage gets in and matures into an adult worm in a human, that adult worm doesn't produce more adult worms inside you.
That they can live for a really long time, right?
An incredibly long time. Some species, certain schistosomes, they've been recorded persisting for up to 30 years.
30 years? Inside a person?
Yes. This extraordinary longevity is why trematode infections are so often chronic. They could persist for decades, causing cumulative damage over time.
The global burden then must be just massive. We might not see these infections much in, say, the US or Western Europe, but worldwide.
Millions, literally millions of people are infected worldwide. And both schistosomiasis and these food-borne trematode infections are deeply, deeply intertwined with poverty.
How so?
They are chronic diseases that cause high morbidity illness, disability leading to significant economic burden. They have a massive public health impact, especially in developing regions.
And things aren't static, are they? There are factors increasing their spread.
Correct. Several interconnected factors are pushing their spread. Climate change, for one. Rising global temperatures are making new geographical areas suitable for those intermediate host snails to thrive.
Expanding their range.
Exactly. Expanding the potential zones of transmission into places they weren't before. At the same time, you've increased international travel and human migration. That contributes significantly to seeing more patients with trematode infections in non-endemic areas. Infected individuals move, and sometimes, if the conditions are right, they can even introduce the parasite cycle to new locations.
It really highlights the evolving dynamic nature of public health challenges in our globalized world, doesn't it?
It certainly is.
Okay, let's delve into the classification and geographic distribution. Our source organizes these infections based on where the adult worms primarily live in the human body. That seems crucial for understanding the specific diseases they cause.
It is. It's very practical. We categorize them based on location. Blood flukes, liver flukes, specifically in the biliary tree, intestinal flukes, or lung flukes.
All right, let's start with the blood flukes. These are all Schistosoma species causing schistosomiasis.
That's right. And what becomes immediately clear when you look at these species is just how specific their environmental needs are. It's like a biological fingerprint for where they can survive.
Okay, give us the rundown.
Schistosoma mansoni causes intestinal schistosomiasis. Its transmission requires specific Biomphilaria snails in freshwater. Geographically, you find it across Africa, parts of Brazil, Venezuela, Suriname, and the Caribbean.
Biomphilaria snails for S. mansoni.
Got it. Then Schistosoma japonicum also causes intestinal schistosomiasis. Transmission involves skin penetration by Cercaria, but this time from Oncomelania snails, primarily found in China, Indonesia, and the Philippines.
Different snail, different region.
Precisely. Then you have Schistosoma guineensis and Schistosoma intercalatum, lesser-known species also causing intestinal schistosomiasis, transmitted by Cercaria from Bulinus snails, mainly in rainforest areas of Central Africa. Schistosoma mekongi, another intestinal type. Transmission via Cercariae from Neotricula apiritus snails, prevalent in specific districts of Cambodia and Lao PDR.
Lao PDR, okay.
And finally, Schistosoma hematobium. This one is unique among the common human schistosomes because it causes urogenital schistosomiasis, affecting the bladder and genitals.
Ah, the urogenital one.
Yes. Its Cercaria are released from Bulinus snails, same genus as S. intercalatum, and penetrate the skin. Its geographic reach covers much of Africa, the Middle East, and even, interestingly, specific pockets like Corsica in France.
Corsica, wow. So each species really does have its own specific snail partner and geographic range.
Absolutely. It's key to understanding its epidemiology.
Okay, moving on to the liver flukes. These seem to be mostly transmitted through ingestion.
Almost universally through ingestion, yes. Typically contaminated food.
Such
Clonorchis sinensis, acquired by ingesting Metacercariae in raw freshwater fish. Found across wide swaths of Asia, Korea, China, Taiwan, Vietnam. Opisthorchis viverini, similar route, raw freshwater fish. Highly endemic in northeast Thailand, Lao PDR, Cambodia, Vietnam.
a lot of overlap in Southeast Asia there.
Yes, dietary habits played a big role. Then Opisthorchis phelinius, also from raw freshwater fish. Prevalent in parts of the former Soviet Union, Kazakhstan, Ukraine, Turkey. And Fasciola hepatica, this one's a bit different in transmission, right?
It is. It's ingested with Metacercaria found on aquatic plants, like watercress, or sometimes directly in contaminated water. And its distribution is truly worldwide.
Global distribution, wow.
And Fasciola gigantica is similar in transmission, found predominantly in Africa and Asia.
Okay, so those are the main liver flukes. What about intestinal flukes?
Fasciolopsis buski, contracted by ingesting Metacercaria on aquatic plants. Its range covers Bangladesh, China, India, Indonesia, Lao PDR, Malaysia, Taiwan, Thailand, Vietnam. Again, heavily Southeast Asia. Echinostoma species, acquired by ingesting various freshwater sources, fish, frogs, mussels, snails. Prevalent across China, India, Indonesia, Japan, Malaysia, Russia, Republic of Korea, Philippines, Thailand.
Quite a diverse diet for those.
Indeed, and heterophes and several related species, ingested via Metacercariae in freshwater or brackish water fish, found in places like Egypt, Greece, Iran, Italy, Japan, Republic of Korea, Sudan, Tunisia, Turkey.
So a wider range, including the Mediterranean and Middle East.
Exactly. And finally, the lung flukes, causing paragonomyosis.
Lung flukes,
Right.
affecting the lungs.
Right, Paragonomus westermani. Acquired by ingesting Metacercariae in undercooked or raw freshwater crayfish or crabs. Its geographic reach includes tropical and subtropical areas of eastern and southern Asia, and also sub-Saharan Africa.
Crayfish and crabs. Okay.
And interestingly, for you listeners in North America, there's an indigenous species, Paragonomus calicoti, same transmission route, crayfish or crabs, primarily found in freshwater systems across the continent, especially Midwest and Southeast U.S.
So it's not just an exotic, faraway problem. There are indigenous species too.
Correct. Which brings us to diagnosis. When approaching a patient where you suspect a trematode infection, that detailed history is absolutely crucial, isn't it?
Crucial. It's not just a formality. That travel, dietary, and activity history directly points us towards the likely species and the route of exposure.
That's a powerful point. The questions are highly specific. You'd ask, where exactly have you been? Not just the country, but the region. When did you return? That helps time the infection.
Hmm.
What specific activities? Trekking, swimming, whitewater rafting, just bathing in fresh water.
All relevant exposures.
And a really big one, what have you been eating? Especially local dishes, raw, poorly cooked, pickled, freshwater fish or crustaceans. That directly ties into the transmission cycles we just mapped out.
Exactly. And key clues that should immediately raise suspicion: the presence of eosinophilia, that elevated count of eosinophil white blood cells. It's a common flag for parasitic infections.
Especially when combined with.
A travel history to an endemic area. That combination is highly suggestive.
But the definitive diagnosis, how do you confirm it?
Primarily, it's based on detecting the parasite eggs, finding the actual eggs in stool, urine, sputum, or sometimes even tissue biopsies. That's the gold standard. Serologic tests, detecting antibodies, are also important tools, providing evidence of exposure, especially in travelers or light infections.
And just a practical note, for anyone needing precise guidance on diagnosis and treatment, maybe for someone who has traveled, the U.S. Centers for Disease Control and Prevention, the CDC, is an absolutely indispensable resource. They keep their guidelines constantly updated.
Excellent resource, yes.
Okay, let's really deep dive now into schistosomiasis. Our source calls it the most important neglected tropical disease. This is where the sheer complexity, the incredible life cycle, and the devastating global impact really come into sharp focus.
Indeed. Etiologically, human schistosomiasis is caused by 6 distinct species of schistosoma. 5 of them, S. mansoni, S. japonicum, S. mccongi, S. intercalatum, and the more recently described S. quinensis primarily cause intestinal disease. They affect the digestive system.
And the 6th.
That's S. hematobium. It's unique among the common ones, specifically targeting the urogenital system, bladder, ureters, genitals. Causes urogenital schistosomiasis.
It's also worth mentioning swimmer's itch, right? That's related but different.
Right. Avian schistosomes from birds can mistakenly penetrate human skin. They cause an itchy rash, swimmer's itch, often in lakes in Europe or North America. But thankfully, they can't complete their development in humans. They just die off in the skin, causing a temporary allergic reaction. No long-term disease.
Okay, good to clarify. Now that life cycle,
Yeah.
you described it as a complex dance. Let's break it down.
It really is. It begins with contact with freshwater lakes, rivers, canals that harbors infected intermediate host snails. Specific snails for specific schistosoma species. The infective larval stage, the cercaria, are released from these snails. They look like tiny tadpoles almost. And they have this astonishing ability to penetrate intact human skin rapidly, often within minutes of contact.
Minutes. That's incredibly efficient.
Highly efficient. Once inside the human body, these cercariae transform quickly. They shed their tails, become schistosomulo, basically juvenile worms. Then they enter small veins or lymphatic vessels, essentially hitchhiking through the bloodstream.
Where do they go?
They circulate, pass through the lung capillaries, get pumped by the heart, and eventually reach the portal vein system within the liver. That's a critical stop.
The liver, okay.
In the portal vein, they mature into adult male and female worms. Once mature, they pair up. The male literally holds the female in a groove.
They pair up for life.
Often for years, yes.
Yeah.
Then they migrate together to their final specific locations, either the mesenteric veins draining the intestines, for the intestinal species, or the pelvic veins draining the bladder and urogenital organs, for S. hematobium.
And how long does this whole process take from skin penetration to egg laying?
That's the pre-patent period, typically about 5 to 7 weeks for most species. Can be up to 12 weeks for S. hematobium. Once mature, that female worm, held by the male, becomes an egg-laying machine.
How many eggs are we talking?
Hundreds per day for the African species like S. mansoni and S. hematobium, and astonishing thousands per day for Asian species like S. japonicum.
Thousands per day.
Per day. And this is where the real pathology starts. About half of these eggs get retained in the host's tissues, trapped. They don't get out.
And those trapped eggs are the problem.
They are the direct cause of the vast majority of the organ-specific morbidity, the illness we see in schistosomiasis. The other half, thankfully, are successfully excreted via feces for intestinal species or via urine for S. hematobium, completing the cycle back into the environment.
Okay, so the eggs that get out continue the cycle. What happens then?
The environmental cycle is equally critical for transmission. When excreted eggs reach freshwater, they hatch, releasing a free-swimming larva called a miracidium.
Miracidium.
Okay.
This miracidium has a short window, maybe hours, to find and penetrate the correct species of host snail. Inside that snail, the miracidium undergoes asexual multiplication, clones itself again and again,
Amplifying the number.
massively amplifying. After about 4 to 6 weeks, infective cercaria are shed from the infected snail back into the water, thousands of them, ready to infect a new human host.
The transmission potential sounds enormous.
It's terrifying, really. One snail infected by just one miracidium can shed thousands of infective cercariae per day for several months. It can turn a small pond into a major infection hotspot.
Astounding reproductive capacity. Now, for diagnosis, you said the egg is key.
The schistosome egg is the only stage of the life cycle reliably detectable in humans, either in excreta or tissue biopsies. They're quite large, morphologically distinct.
You can tell the species apart by the egg. Often, yes. S. hematobium eggs are about 140 micrometers long, distinctive terminal spine at one end. S. mentoni eggs are around 150 micrometers, prominent lateral spine sticking out the side. S. japonicum eggs are similar, but usually have just a small lateral spine or knob. These differences are visible under a microscope.
And the adult worms themselves, how big are they?
About 1 to 2 centimeters long. The male worm is flat, has that unique groove, the gynecophoric canal, where it holds the longer, thinner, more rounded female worm. It's a structural adaptation for continuous reproduction.
Keeping them aligned. And they live, potentially, for decades.
Average lifespan often cited is 3 to 5 years, but yes, they can persist for up to 30 years. Imagine that, living inside your bloodstream for 3 decades.
How do they survive our immune system for so long?
They feed on red blood cells, and the resulting debris, their waste products, are regurgitated. These are detectable at circulating antigens, which helps with diagnosis. But their real trick is immune evasion.
How do they evade it?
They actively bind host proteins onto their surface. They essentially coat themselves in self-molecules, rendering themselves invisible or non-threatening to our immune response. A remarkable adaptation for long-term survival.
Wow, cloaking themselves.
Pretty much. And understanding these parasites is a major scientific focus. Their genomes are relatively large, around 300 megabases. We have whole genome sequences for the main species, S. mansoni, S. japonicum, S. hematobium.
Which must help researchers look for vulnerabilities.
Exactly. It signifies a huge research effort trying to unlock their secrets.
Okay, let's talk epidemiology. Where does this happen and why? You mentioned the life cycle dictates the location.
Absolutely. Transmission is highly dependent on that specific interplay. Suitable freshwater habitats for the specific snails, areas of frequent human water contact, and the right climatic conditions for both snail survival and parasite development within the snail. That's why you see such specific global and even very localized microgeographic distributions. It's a geographical puzzle dictated by biology.
And who are the main hosts?
For S. mansoni, S. hematobium, S. intercalatum, and S. quiniensis, humans are considered the most important, often the only, significant definitive host.
But not for all species.
No. S. japonicum and S. macongi are particularly challenging because they're zoonotic.
Meaning they infect animals, too.
Yes, they can infect a wide range of definitive hosts, humans, but also pigs, water buffaloes, various rodents. This massively complicates control efforts. You can't just treat humans, you have to manage the animal reservoirs too.
The numbers, again, just to reinforce the scale.
Estimated 229 million people infected globally. Transmission reported from 78 countries, but 52 have moderate to high transmission. Over 70% of all infected individuals live in sub-Saharan Africa.
It really cements its position as the most important neglected tropical disease, second only to malaria in impact.
Correct. And its label as a poverty-related disease is incredibly apt. Infection is highly prevalent where safe water and proper sanitation are lacking.
People just don't have a choice but to use contaminated water.
Often, yes. Daily activities, bathing, washing clothes, collecting water, essential stuff. Certain occupations are high risk too. Fishermen, canal cleaners, race field workers, sustained contact with infested water.
And kids?
Kids playing and swimming in water. Major risk factor. Leads to early and repeated infections.
And human activity can make it worse, like building dams.
Yes, that's a crucial point. Large-scale irrigation projects, hydroelectric dams, while beneficial in some ways, can inadvertently create vast ideal habitats for host snails. unintended consequences that significantly increase risk and spread.
There's a characteristic pattern with age, too, isn't there?
Yes, the age prevalence curve. Kids in endemic areas usually get their first infection around 3 to 4 years old when they start having more water contact, though it can happen even earlier. Then as they get older, both prevalence, the percentage infected, and intensity, the number of worms, tend to increase. They peak around puberty, say 10 to 15 years old.
But then it drops off in adults. Why?
It does. A noticeable decline. Several factors contribute. Kids generally have more frequent, prolonged water contact playing, swimming, higher exposure. Plus, it seems a substantial acquired immunity develops, but slowly, over years of repeated exposure. Adults get reinfected less effectively than kids because their immune system starts to fight off new infections better.
Ah, acquired immunity.
Combine that with the gradual spontaneous death of adult worms acquired during childhood, and you see that decline in adults. It's a complex interplay.
Okay, let's get into pathogenesis.
Yeah.
How does the disease actually develop and cause harm? You mentioned it's not really the worms.
Well, the initial cercarial invasion, the skin penetration, can cause a temporary dermatitis, an itchy rash. That's an inflammatory reaction to the dying cercaria.
Swimmer's itch, basically.
Similar idea. But the vast majority of the morbidity, the illness, the damage, whether it's acute, established, or chronic, is fundamentally due to the immunologic reactions to the eggs trapped in host tissues.
That's the critical point again. It's the eggs.
It's the eggs, not the adult worms themselves causing the primary pathology. It's the body's powerful, often excessive immune response trying to deal with these trapped eggs.
So what happens when the eggs get trapped, let's say in the intestines or liver for S. mansoni or S. japonicum?
Right. About half the eggs don't get excreted. For those species, they get lodged in the intestinal wall or swept by the portal blood flow into the liver. For S. hematobium, they get trapped primarily in the bladder wall and urogenital system. These trapped eggs trigger a powerful granulomatous immune response. The body tries to wall them off. It forms a granuloma, a localized collection of immune cells like lymphocytes, eosinophils, macrophages around each egg.
And the immune system signals, the cytokines play a role.
A big role. In the acute phase, certain Th2 cytokines, IL-4, IL-5, IL-13, drive that initial intense inflammation around the eggs. Later, in the chronic phase, a different set of regulatory cytokines kicks in. They actually downregulate the response, modulate the immunity. This is sort of beneficial as it reduces the size of the granulomas and mitigates some of the pathology. It stops the immune system from going completely overboard.
Okay, so in the liver with S. mansoni or S. japonicum, these granulomas form around eggs trapped in the portal branches.
Yes, they lodge in the presenocytal periportal tissues. The granulomas cause inflammation and swelling, leading to enlargement of the liver and spleen hepatosplenomegaly. You see this often in kids with heavy infections. It tends to decrease over time.
But it can get much worse, right? The long-term consequences.
It can. In some individuals, especially with chronic heavy infections, these egg-induced granulomas lead to severe periportal fibrosis, scarring around the portal veins.
That's Simmer's clay pipestem fibrosis?
Exactly. A very specific, severe form of scarring. Extensive deposition of collagen, that tough fibrous protein. It occludes, blocks off the smaller portal branches, damages the liver architecture severely. This blockage results in marked portal hypertension, a dangerous increase in pressure in the portal vein system, and that can lead to life-threatening complications.
Okay, now shifting to S. hematobium and the urogenital system, what happens there with the trapped eggs?
The signs and symptoms relate directly to egg deposition in the bladder wall, ureters, genitals. During active infection, you get clusters of living eggs surrounded by intense inflammation, lots of eosinophils in the tissues. As these egg clusters move towards the bladder lumen, the inner lining, it often causes sloughing of the surface, ulceration, bleeding. That's why you see hematuria blood in the urine.
And this inflammation can cause physical changes to the bladder.
Yes, chronic inflammation can lead to bladder wall thickening, the formation of masses, pseudopolyps. These can even be mistaken for tumors. And crucially, inflammation and granuloma formation right where the ureters enter the bladder, the ureteral ostia, can lead to blockage, ureteral obstruction.
Blocking the flow from the kidneys.
Exactly. That causes hydroveter dilation of the ureter and hydronephrosis. Urine backs up, swelling and damaging the kidney. These early inflammatory changes, including the obstruction, can be clearly seen and monitored with ultrasonography.
And in the chronic stage?
As infection becomes chronic, the acute inflammation lessens, but fibrosis, scarring becomes more prominent. Symptoms might include nocturia, peeing a lot at night, urine retention, dribbling, incontinence. If you look inside the bladder with a cystoscope, you might see characteristic sandy patches. Those are basically calcified eggs embedded in fibrous tissue with a thinned, atrophic mucosal surface.
And the scarring can cause permanent damage.
Yes. While less common, ureteral fibrosis can cause irreversible obstructive uropathy, permanent kidney damage. If untreated, it can progress to uremia kidney failure.
There's also involvement of the genital organs.
Yes, that's a significant issue. Egg deposition causes granulomas and lesions, most commonly cervix and vagina in women, seminal vessels in men.
What kind of symptoms would that cause?
In women, painful intercourse, dyspareunia, abnormal vaginal discharge, contact bleeding, persistent lower back pain. For men, perineal pain, painful ejaculation, hematospermia, blood and semen.
Our source notes specific things like bloody discharge or genital itch in schoolgirls and hematospermia in travelers.
That's right. And there's also a demonstrated association between female genital schistosomiasis and HIV infection. The exact impact on HIV transmission, whether it increases susceptibility or spread, needs more study, but the link is there.
And here's a really critical point, something professionals absolutely grasp: the cancer link.
Yes, S. hematobium has been classified by the International Agency for Research on Cancer, IARC, as a Group 1 carcinogen.
Yeah.
Meaning it is definitively carcinogenic to humans. Chronic S. hematobium infection is strongly associated with developing squamous cell carcinoma of the urinary bladder.
A direct link from parasite to cancer, that's profound.
It's a devastating long-term impact.
Beyond the main organ systems, these worms and eggs can sometimes end up in ectopic sites in unusual locations.
They can. Neuroschistosomiasis is one of the most severe forms, caused by the inflammatory response around eggs that somehow lodge in the brain or spinal cord venous plexus.
What happens then?
For S. mansoni and S. hematobium, they tend to end up in the spinal venous plexus. Can cause transverse myelitis, acute inflammation of the spinal cord, leading to rapid paralysis, sometimes seen in travelers returning from endemic areas.
Paralysis. Scary.
Very. Schistosoma japonicum is more associated with granulomatous lesions in the brain itself. Can cause severe neurological symptoms, epileptic seizures, encephalopathy, general brain dysfunction with headache, visual problems, motor deficits, loss of coordination, ataxia.
And the lungs can be affected too.
Yes, pulmonary schistosomiasis happens when eggs are shunted from the chordal circulation, bypass the liver somehow, and end up in the lung capillaries. They induce granulomas around the air sacs. Long-term consequences: progressive fibrosis, scarring of the lungs, leading to pulmonary hypertension, high blood pressure in the lung arteries, and eventually core pulmonale heart failure affecting the right side of the heart, caused by the lung disease.
So a wide range of potential damage depending on where the eggs land. How do we actually pinpoint the problem, diagnose schistosomiasis?
It starts with that crucial patient history, the anamnestic information, asking about travel to endemic areas, freshwater exposure. Knowing the exact locations helps identify the likely species.
And that initial clue?
Eosinophilia. That elevated eosinophil count is often the first flag. But the gold standard, the most direct diagnostic method for confirming active infection, is detecting the schistosome eggs.
In stool or urine, primarily.
Right. It's widely used, especially in endemic areas. And you can quantify the infection measure eggs per gram of feces, or per 10 milliliter of urine. That egg count correlates with infection intensity and disease severity.
But it can be hard to find the eggs in light infections.
They can, especially in people from non-endemic areas or those with low worm burdens. Egg excretion can be very low. You might need larger samples or concentration methods like formal ether concentration to increase the chances of spotting them, like finding a needle in a haystack.
Where else can you find eggs?
Rectal biopsies can be useful, especially for S. mansoni and S. hematobium. Occasionally, they show up in pap smears or semen samples for urogenital schisto.
What about more modern methods, like DNA detection?
Yes, molecular methods are increasingly used. PCR-based detection amplifying parasite DNA in stool or urine is more sensitive than microscopy. Remarkably, you can even detect schistosoma DNA in circulating cell-free DNA in the host's blood, a promising non-invasive approach.
And serology, antibody tests.
Very useful, particularly in travelers, for identifying early or light infections, or just confirming past exposure. Less useful in people from endemic areas because ongoing transmission means almost everyone has antibodies, making it hard to distinguish current from past infection. The CDC uses specific assays, a screening fast ELISA, and then a confirmatory, species-specific immunoblot based on travel history for accuracy.
And what about detecting antigens, products from the worms themselves.
That's a very promising and evolving area. Detecting schistosome proteoglycans specifically, circulating anodic antigen, CAA, and circulating cathodic antigen, CCA.
Where do these come from?
They're unique molecules actively regurgitated into the bloodstream by the feeding worms. They act as a direct biomarker of active infection.
Can you measure them?
Yes, in serum and urine, using ELISA or lateral flow assays, like a pregnancy test strip. Their presence indicates active infection. And importantly, the levels correlate well with infection intensity, giving a quantifiable measure of worm burden.
Are these ready for prime time, especially for travelers with low infections?
Current lab methods aren't quite sensitive enough for those very low-level infections yet. But exciting progress is being made with ultra-sensitive lateral flow assays, much more sensitive and rapid. And for community use, there's a commercially available point-of-care CCA urine assay. It's widely used now for screening communities in mass drug administration programs. Helps quickly identify who needs treatment on a large scale.
Okay, treatment. What's the go-to drug?
The drug of choice, overwhelmingly, is praziquantel.
Praziquantel.
Yes. Administered orally, usually 600 milligram tablets, it's remarkably effective against all schistosome species infecting humans. Plus, it's considered very safe and generally well tolerated, even when used in mass campaigns.
And the dosage, does it vary by species?
It does. Standard regimens are important. For S. mansoni, S. hematobium, S. intercalatum, S. guineensis, it's typically 40 milligilokilograms orally, given in 2 divided doses over 1 day. For S. japonicum and S. macongi, it's a higher dose. 60 milligilokilograms orally, usually in 3 divided doses over 1 day.
What if the first treatment doesn't work or you get reinfected?
The same dose can be repeated, maybe weekly intervals for a couple of weeks or just retreat after a few months. But there's a key point about praziquantel's action. It doesn't work well against the young migrating stages, the schistosomia, right after skin penetration.
Ah, so timing matters.
It does. If eosinophilia or symptoms persist after initial treatment, you might need to repeat the dose 6 to 12 weeks later. That delay allows those young stages to mature into adult worms, which are susceptible to the drug.
What about treating acute schistosomiasis, Katayama fever?
All patients diagnosed with it should get praziquantel to target the adult worms. If they have severe hypersensitivity reactions, fever, rash, etc., due to the immune response to the eggs, glucocorticoids like prednisone can be added to suppress that excessive response. Severe cases often need hospital care.
And neuroschistosomiasis, brain or spinal cord involvement.
Praziquantel is highly effective there too. Leads to rapid dissipation of brain swelling, edema, and resolution of those granuloma masses. Sometimes, though, glucocorticoids and anticonvulsants are still needed to manage seizures or severe inflammation.
How well does treatment reverse the damage already done? Does it depend on the stage?
It absolutely depends on the stage and severity. Early stage conditions, enlarged liver spleen, mild moderate fibrosis, active bladder lesions typically resolve or significantly improve after praziquantel. It prevents further damage.
But late-stage disease, severe fibrosis, portal hypertension.
There, the damage is often extensive and irreversible. Praziquantel is only one component of management. It kills the worms, stops further egg laying, but the main complications are now from the established scarring, the obstructive pathology. So, managing portal hypertension, preventing bleeding from esophageal varices that follows general clinical guidelines for those conditions, it goes beyond just killing the parasite. It highlights the need for comprehensive, multidisciplinary care in chronic advanced cases.
Okay, so prevention and control must be multifaceted then for travelers.
Awareness is crucial. Informing them thoroughly about the risk of infection from freshwater contact in endemic areas, reminding them that clear-looking water isn't necessarily safe.
But for people living there, avoiding water is often impossible.
Exactly. For occupational reasons, fishing, farming rice, or just daily needs, it's extremely difficult, often impossible.
Underscoring that poverty link again, lack of safe water and sanitation.
Precisely. And for S. japonicum, the zoonotic one, prevention has to target the animal reservoirs, like water buffalo, in addition to humans. Adds another layer of complexity.
So what's the cornerstone of control in endemic areas?
Praziquantel treatment of infected people, often delivered through mass drug administration MDA programs. Regular treatment significantly reduces morbidity, the illness, and suffering.
But treatment alone isn't enough for long-term control.
No, it must be combined with other strategies for sustainable impact.
Such as?
Control the intermediate host snails using melisicides or environmental management, improving water quality, access to safe water, water treatment, enhancing sanitation facilities to stop eggs getting back into water sources, robust health education to change risky behaviors.
And integrating these efforts.
Yes, schistosomiasis control needs to be integrated into broader local health programs. Embed it within the existing healthcare infrastructure for sustainability and reach.
What about a vaccine? Any progress there?
Intensive global efforts, yes, given the huge burden, but unfortunately none is currently available for widespread use.
Our source mentioned some trials.
Yes, a couple candidates in early phase 1 safety trials, one in phase 2 efficacy trials. Only one candidate, S. hematobium 28 GST, made it to a large phase 3 trial in an endemic population.
And the results?
It was immunogenic,
Hmm?
provoked an immune response, and well tolerated. But unfortunately, it didn't achieve sufficient efficacy to prevent infection or severe disease.
So still a major challenge.
A huge challenge. Developing effective parasitic vaccines is notoriously difficult. It remains an important area of ongoing research and hope.
Okay, let's shift gears now. Let's talk about food-borne trematode infections. This sounds like another fascinating, maybe overlooked journey from plague to pathology.
It is a diverse group of zoonotic diseases caused by hepatic, liver, intestinal, and pulmonary lung flukes.
And transmission is pretty direct.
Yes, ingestion of infective parasites in undercooked aquatic food fish, crustaceans, or from aquatic plants.
The global impact, is it significant?
It's substantial, estimated 71 million people infected globally,
Mhm.
causing an estimated 2 million delecies disability-adjusted life years annually.
2 million years of healthy life lost each year. That's a big deal.
It represents a significant global health burden, absolutely.
Okay, let's break down the liver flukes first. Opisthorchiasis, clonorchiasis, fascioliasis.
Right. The most important ones causing human liver infections are Opisthorchis viverrini and Opisthorchis folineus, causing opisthorchiasis,
Hmm.
Clonorchis sinensis, chlororchiasis, and Fasciola hepatica and Fasciola gigantica, fascioliasis.
Where are these found mainly?
Geographically, Opisthorchis viverrini is tightly linked to northeast Thailand, Laos, Cambodia, deeply ingrained in local cuisine there. Opisthorchis folineus is more across Europe and Asia, including the former Soviet Union. Clonorchis sinensis is widespread across large parts of Asia, Korea, China, Taiwan, Vietnam, Japan, Asia, and Russia, again reflecting dietary habits and intermediate host presence.
And their life cycle involves intermediate hosts, like snails and fish.
Yes, a multi-stage process. Eggs from infected human animals get ingested by a specific snail, first intermediate host.
Yeah.
Parasites develop and multiply asexually inside. Cercariae are released, penetrate freshwater fish, second intermediate host. They encyst as metacercariae in the fish muscle or under scales.
And humans get infected by eating that fish raw or undercooked.
Exactly. After ingestion, the metacercariae cysts emerge in the stomach's gastric juices. Then they migrate via the duodenum up the common bile duct to finally reach and settle in the bile ducts of the liver.
What kind of problems do they cause there? Opisthorchis and clonorchis.
Clinical manifestations are similar, primarily affect the biliary system, bile ducts, liver tissue, gallbladder. You get tissue damage, intense inflammation from mechanical irritation by the worms, and the immune response to them and their waste products.
And the really critical point here, the cancer link again.
Yes, this is incredibly important. Chronic inflammation caused by these long-term infections can lead to cholangiocarcinoma, bile duct cancer. It's often aggressive and fatal. Both Opisthorchis viverrini and Clonorchis sinensis are classified by IRC as Class 1 carcinogens, definitively carcinogenic to humans. A profound reason why these infections matter.
Wow. Are infections always severe?
Acute and light infections are often mostly asymptomatic. Some patients, especially with ophilinius, might get hepatitis-like symptoms, fever, chills. Generally, only heavily infected people experience significant symptoms and severe complications, like that chronic inflammation leading towards cancer.
How are they diagnosed? Stool samples.
Diagnosis relies on microscopic ID of parasite eggs in stool, but a significant challenge. The eggs of Opisthorchis look identical to those of Clonorchis under a standard microscope. Need more advanced techniques for species differentiation sometimes.
Okay, now for fascioliasis. Fasciola hepatica and gigantica, where are they found?
F. hepatica is common in sheep and cattle, found in over 50 countries, truly global. F. gigantica is less widespread. Highest human infection rates are in the Andean highlands, Bolivia, Peru, linked to eating watercress. Static human cases occur elsewhere.
And their life cycle is different. No second intermediate host.
Correct. That's unique among these liver flukes. Infectious metacercaria adhere directly to aquatic plants like watercress, or can even float freely in water.
So humans get infected by eating the plants like watercress or drinking contaminated water.
Exactly. Ingesting the metacercaria that way simplifies their life cycle compared to Clonorchis or Opus thorchis.
But their migration inside the body is more complex, more brutal.
It is. After existing in the duodenum, fasciola don't just go straight to the bile ducts. They actively migrate through the intestinal wall into the body cavity, penetrate the liver capsule, and then move through the liver parenchyma, the functional tissue itself, before finally reaching the bile ducts.
Tunneling through the liver?
Yeah.
Ouch.
Yes. This extensive migration causes significant tissue destruction, focal bleeding, intense inflammation. That's responsible for the acute migratory phase symptoms. Sometimes migrating flukes even go off course, causing ectopic infections in unusual places, lungs, brain, skin.
And once they reach the bile ducts, the latent stage.
They cause chronic inflammation of the bile ducts, leading to thickening, expansion, fibrosis, eventually biliary obstruction. Some people might be asymptomatic then. Others can have relapses of acute symptoms.
Diagnosis, eggs in stool again?
Direct detection of fasciola eggs in stool, or duodenal aspirate, is the main way. Antibodies might be detectable 2-4 weeks post-exposure. Important note, multiple stool specimens might be needed, especially in light infections where egg shedding is intermittent.
Okay, let's quickly cover intestinal flukes. Many species, right?
Over 70 species known to cause human infection, a relatively high prevalence, especially Southeast Asia.
Infection rate?
Ingestion of metacercaria, either on aquatic plants like Fasciolopsis busci, or encysted in freshwater fish. Flukes mature in the human intestines.
Symptoms, mostly GI stuff.
Mechanical irritation, inflammation. Leads to nonspecific GI symptoms, diarrhea, constipation, abdominal pain. Most mild infections are asymptomatic, but heavy infections can be severe. Intestinal mucosal ulcerations, malabsorption of nutrients, that can lead to malnutrition, anemia, rarely ectopic infections outside the gut.
Diagnosis is egg detection in stool, but tricky.
Yes, egg detection in stool. But the caution here is crucial. Eggs from different intestinal trematodes often look very similar morphologically. Extremely difficult to distinguish species reliably. For example, fasciola eggs, liver fluke, can be hard to tell apart from Fasciolopsis busci eggs. Intestinal fluke. This is critical because praziquantel works for F. busci, but not for fascioliasis, which needs triclobendazole. Misidentification leads to treatment failure.
Good point. Finally, lung flukes. Paragonomyosis.
Right, a parasitic lung infection caused by Paragonymous species. It's a food-borne zoonosis, mostly from eating raw or undercooked freshwater crustaceans.
Crabs and crayfish again, where is it common?
Most cases from Asia, Paragonymous westermae. Also found in West Africa, Central South America. And remember, Paragonymous kellicati is indigenous to North America, linked to eating native crayfish, especially in Midwest, Southeast U.S.
Life cycle needs 2 intermediate hosts.
Yes. First, a freshwater snail. Second, a freshwater crustacean, crab or crayfish. Humans get infected by eating raw undercooked infected crustaceans with metacercaria. Other carnivores, cats, dogs, foxes, pigs, can also be hosts, creating a reservoir.
And their migration is also quite a journey.
Remarkable. After ingestion, metacercaria penetrate the duodenum, traverse the peritoneal cavity, pierce the diaphragm, penetrate the pleura, and finally mature into worm pairs in the pleural spaces or lungs. Takes 6-10 weeks. They cross-fertilize in cystic cavities there, another 4-16 weeks, then release eggs. Eggs get coughed up in sputum, giving it a rusty color, or swallowed and passed in feces.
Symptoms sound like they could mimic other lung diseases.
Very much so. Fever, chronic cough, hemoptysis, coughing up blood, often rusty brownish sputum, peripheral eosinophilia, can closely mimic tuberculosis, chronic cough, sputum, fever, night sweats. Makes diagnosis challenging.
And they can end up outside the lungs too.
Yes, metacercaria can migrate elsewhere. Most notably, the brain cerebral paragangliosis, a severe complication, can cause cysts in lungs or ectopic infections in eyes, skin, heart, abdomen, reproductive organs.
Diagnosis relies on finding eggs.
Primarily, yes, ova detection in sputum and/or feces. Serology, antibody tests, is helpful for egg-negative cases or cerebral paragangliosis, and that history is vital. Asking about eating raw undercooked freshwater crabs or crayfish, especially for immigrants, travelers, or even people in the U.S. presenting with puzzling symptoms like fever, cough, bloody sputum, pleural effusions, and eosinophilia. Gotta ask about crayfish consumption.
Treatment for these food-borne trematodes, praziquantel again.
Praziquantel and triclobendazole are the 2 main drugs. The choice depends on the specific species.
For example.
For Clonorchis, Opus thorchis, usually praziquantel, Rugosa 25 mg calamzit 3 times daily for 2 days. For fasciola, which resists poisia, it's triclobendazole, for example, 2 doses of 10 mg/kg 12 hours apart. For intestinal flukes like fasciolopsis, echinostoma, praziquantel is effective. You table 75 mg/kg in 3 doses for 1 day.
And for paragonomyosis, treatment is essential.
Absolutely essential. All confirmed cases must be treated with praziquantel. This is to prevent those severe, potentially lethal extrapulmonary complications, especially brain involvement. Surgery might sometimes be needed for large lung or brain lesions.
Control and prevention. Drugs are key.
Drugs, often via mass treatment programs, are the main method currently for controlling morbidity. But for sustainable control, you need integrated programs.
Meaning?
Improved sanitation, rigorous food inspections, strong information, education, communication, IEC campaigns about safe food prep, and dangers of raw aquatic foods.
And it requires collaboration.
Absolutely. Tackling these complex situations involving human behavior, biology, agriculture needs cross-sector work. Agriculture, environment, education, public health, all working together. It's a holistic challenge.
Okay, a lot to digest there on trematodes. Let's transition now, maybe more briefly, to Chapter 235 from our source, cestode infections. Tapeworms, another fascinating group of flatworms.
Indeed. Cestodes, segmented flatworms, ribbon-shaped, quite distinct from the leaf-like flukes. And where they live matters. The adult worms usually reside in the human gastrointestinal tract, often causing relatively mild symptoms there.
But the larvae?
The larvae. They can be found in almost any organ of the human body. And that's where you get much more severe, sometimes life-threatening conditions.
How are human tapeworm infections generally categorized?
2 major clinical groups based on which stage is in the human. First, humans as definitive hosts. Adult tapeworms in the GI tract. Examples: Taenius aginata, beef tapeworm; Diphyllobothrium, fish tapeworm. Second, humans as accidental intermediate hosts. We harbor the larval stages in our tissues. This includes serious diseases like echinococcosis, hydatid disease, sparganosis, conerosis.
And sometimes humans can be both.
Yes, a dual role. For Taenius solium, the pork tapeworm, humans can host the adult worm in the gut and the larvae, Schistosomiasis, in tissues, including the brain. That's neurocystosarcosis, devastating. And for Hymenopus manna, the dwarf tapeworm, both adult and larval stages are found simultaneously in human intestines. It completes its entire life cycle within a single human host. Unique.
Morphology of the adult tapeworm, it has a head.
A head, called the scolex. It uses this to attach to the intestinal lining using sucking cups and sometimes hooks, like an anchor.
And the body.
Behind the scolex is a short neck, the growth region. From this neck, segments, called proglottids, continuously form. New ones push older ones back, creating that long chain, the strobila.
And they can get really long.
Some species, yes.
Yeah.
Over 1,000 proglottids, measuring several meters, truly remarkable. Each mature proglottid is hermaphroditic, containing both male and female organs, producing thousands of eggs.
Diagnosis can be tricky though, right? Especially with Neomia eggs.
Very tricky. The eggs of different Taenia species, specifically T. saginata beef and T. solium pork, look identical under the microscope. So species-level diagnosis requires looking for subtle differences in the scollices or the proglottids themselves, often need the actual segment.
Life cycles are complex too, usually need an intermediate host.
Most human tapeworms need at least one intermediate host for larval development, yes.
Yeah.
The cycle starts when that host, often an animal, eats the eggs or proglottids. Inside, the invasive larva, the oncosphere, hatches, penetrates the intestinal wall, enters the bloodstream.
And travels to tissues.
Migrates via circulation to various tissues, then develops into an assisted larval form. These forms vary.
Like what?
A cysticercus, a fluid-filled bladder with a single scolex inside, like a seed, a conurus.
Yeah.
Similar, but multiple scollices inside. Then the hydatid cyst, echinococcosis. Large, can grow huge, contains daughter cysts inside, each packed with hundreds of tiny protoscollices, undeveloped heads. Very complex.
And the cycle completes when the definitive host eats the cyst.
Exactly. If a human eats tissue containing one of these cysts, the scolex, or scoliosis, evaginates, attaches, and develops into a mature tapeworm in the intestine.
Okay, let's look specifically at Taenius saginata
Beef tapeworm.
and Taenius asiatica. Where are they found?
T. saginata is worldwide. Basically, anywhere raw or undercooked beef is eaten. Most prevalent in sub-Saharan Africa, Middle East. T. asiatica is closely related, found in Asia, uses pigs as intermediate hosts, interestingly, reflecting diets there.
But clinically, they're similar.
Very similar clinical manifestations and morphology, often discussed together. For both, humans are the only definitive host for the adult stage.
How big do they get?
Impressive. Up to 8 meters long, 1,000, 2,000 proglottids. They live in the upper jejunum, the small intestine.
Any differences to tell them apart? The
Hmm.
scolex?
Subtle but important ones. T. saginata beef has 4 prominent suckers, but no hooks. T. asiatica has an unarmed rostellum lax hooks too, which helps distinguish it from T. solium pork, which does have hooks. Also, the gravid segments, the egg-filled ones, differ in uterine branches. T. saginata has more, 15-30 branches. T. solium has fewer, 8-12,
But the eggs look the same.
indistinguishable from T. solium eggs. Sphericalavoid, 30-40 micrometers, 6 hooked oncosphere inside, thick brown striated shell, look identical. And these eggs are tough. On vegetation, they can survive for months, even years, waiting to be eaten by cattle, T. saginata, or pigs, T. asiatica.
Once eaten by the cow or pig, the embryo hatches, invades muscle, transforms into a cysticercus. Humans get infected by eating that raw, undercooked, measly meat.
Precisely. Ingest the meat with the cysticercus. In the human intestine, the cysticercus evaginates, turns inside out, attaches. Takes about 2 months to mature into an adult tapeworm, which then starts shedding thousands of eggs daily. Cycle continues.
Clinical manifestations. How do people know they have it?
Most patients find out quite directly, often disturbingly, by
Yeah.
noticing the passage of proglottids, those segments, in their feces.
And T. saginata segments are motile. They can crawl.
They can. They actively crawl out of the anus sometimes. Causes perianal discomfort, itching, and understandably considerable alarm.
Yikes. Other symptoms. Usually mild.
General symptoms are often mild and nonspecific. Mild abdominal pain discomfort, nausea, maybe a change in appetite, more or less hungry, feeling weak, some weight loss. The adult worm itself usually doesn't cause severe problems, unlike the larval forms of some other tapeworms.
Well, we've certainly taken a profound deep dive today, haven't we? Just covering so much ground.
We really have. It's a complex world.
From understanding the unique challenges of, say, eradicating Ricunculiasis with its visible worm, to navigating the incredibly intricate, often quite alarming life cycles of trematodes and cestodes. We've covered a vast, unseen world of parasites. We explored how these flatworms, the complex flukes with their multi-stage aquatic cycles, the segmented tapeworms with their dual host roles, how they infect us, cleverly evade our defenses
Those evasion strategies are fascinating.
and cause just a huge spectrum of diseases. Everything from mild GI upset to severe chronic organ damage and even, devastatingly, cancer. Our mission was to give you that elite professional level understanding. And I think we've truly unpacked the core of Chapter 234 and beyond, really hitting the why behind the what.
I agree. We saw how trematodes, particularly the schistosomes, even though they don't multiply inside us as adults, can live for decades, leading to chronic, debilitating poverty-related diseases, and we keep hitting that key point. The pathology of schistosomiasis comes primarily from the body's own powerful, often damaging immune reaction to the trapped eggs, not the adult worms themselves.
Right, it's the eggs causing the chaos.
And how those seemingly innocuous eggs can lead to severe conditions like irreversible periportal fibrosis in the liver or for schistosoma hematobium, that direct link to bladder cancer.
And we didn't shy away from the food-borne trematodes either, highlighting that critical, sometimes life-threatening link between eating undercooked aquatic foods and diseases like oprostorchiasis, clonortiasis, carrageenomyiasis.
And the fact that some of those are classified as IRC Group 1 carcinogens, definitely causing cancer. That's a stark, vital reminder about food safety and proper cooking.
Then we touched on the segmented cestodes, the tapeworms, their unique scolex and proglottids, how humans can be definitive hosts or accidental intermediate hosts, leading to adult tapeworm infections or, much more seriously, those larval tissue diseases like cysticercosis, which can just wreak havoc in vital organs like the brain.
Understanding these complex diseases, even if they seem rare where you live, it provides really crucial insight into the interconnected global health challenges we all face.
Yep.
Well, it illuminates that intricate relationship between human health and the environment, water sources, food chains, climate, and it profoundly highlights the immense challenges of disease control in poverty-stricken areas, where basic sanitation, safe water, proper food handling, they remain significant, often insurmountable barriers to health.
So what does this all mean for you, our listener? Perhaps it's a profound reminder of this unseen, complex world all around us, teeming with life, and how absolutely vital public health infrastructure is. Everything from safe drinking water and effective sanitation to robust food inspection, public health education, it's all critical, not just for preventing dramatic diseases like dracunculiasis, but for mitigating the insidious long-term spread of these incredibly resilient, often ingenious flatworms. What stands out to you most? Is it the extraordinary longevity or the cleverly complex life cycles of these parasites? And how does that underscore the ongoing challenges in global health? Something to think about.
It truly makes you appreciate the delicate balance of ecosystems, doesn't it?
Yeah,
And just how crucial sustained public health efforts really are.
absolutely. Well, thank you for joining us on this very deep dive into the world of trematodes and cestodes. Keep asking questions and keep exploring.